Yeah, so when you talk about thyroid disorders, then we have to know that there are particular patient populations or a particular age groups where thyroid disorders are more common and you cannot afford to miss them. So the most important part is in pregnancy with thyroid, because your mother's health as well as the child's health is dependent on the thyroid hormone. Then in newborn age group, where we are doing a neonatal screening for thyroid hormone, you have to pick these patients up. In elderly age group, where there are incidents of cardiovascular diseases where thyroid plays an important role, that's one area where we have to look at. And patients with autoimmune disorders, where they have other organ involvement and we need to pick these patients earlier. Another important part is as a part of general population screening. These disorders are more commonly seen in reproductive age groups in females, and if a mother has hypothyroidism or thyroid disorder, the chance of transmitting it to offspring or the daughter increases almost 3 to 4 times. We need to pick these patients earlier by doing a simple T3, T4 or free T3, T4 and TSH assays. So when you talk about interpretation of T3, T4, TSH in clinical situations, we have to be aware that these T3, T4, TSH assays have become very good. They have become very sensitive, and there are few minor clinically important points which we need to know about them. It is definitely a very good assay to pick up earlier evidence of hyperthyroidism or hypothyroidism, where in hyperthyroidism TSH is suppressed and in hypothyroidism TSH is increased. So it can pick up all overt cases as well as subclinical cases, but few things as a clinician we need to remember, that there could be a falsely altered test. For example, TSH may be suppressed if the patient is on drugs like biotin. So biotin is very commonly used for hair fall treatment and it can temporarily suppress TSH if you are using it. We need to stop the biotin for 4 to 5 days or maximum a week and repeat the TSH. You will get your answers which are right. In pregnancy, in early pregnancy, because of high HCG, TSH may be suppressed, where FT3, FT4 is normal, and which could be a normal counterpart of variation because of the assay use interference. And so we need to be aware of it so as to avoid over treatment in these patients. Another common fallacy is that in obesity, TSH may be upregulated and there is mild increase in TSH, which needs to be known that the treatment would be loss of weight and not treating with thyroid hormone, and this is a clinical counterpart we need to be aware of. When we talk of thyroid function test and T3, T4, TSH assays, there is a sea change which has occurred over last 40 to 50 years, where earlier the first generation assays were radioimmunoassays, second generation assays were IRMA or ELISA, which has improvised. So from the first generation to second generation and third generation CLIA was there, and now we have an ultra sensitive TSH by CLIA only, which is a further refinement of the axis, where you can see the TSH pickup or the sensitivity has gone to almost 1000-fold, from 0.01 to 0.0001, which tells us that this test is very good to not only pick up overt cases but even slight alterations in this axis or the earliest axis where there is no clinical evidence of any disease. You have a subclinical case, then also this T3, T4, TSH would pick up all your disorders of hypothyroidism, hyperthyroidism and euthyroidism. It is particularly important to pick up cases in the earlier part of the diagnosis before any clinical change, and also it is very good for controlling your thyroid disorder, where you can, the precision of treatment as well as for diagnosis is improved because of these assays.